Hello and welcome to Bottom Line. We have a terrific show for you today. We're going to learn about skin cancer. And my guest for today's show is a board certified dermatologist and also has her own private practice in Farmington Hills, Michigan. I'd like to welcome Dr. Wendy Sadoff to Bottom Line. Dr. Sadoff, welcome to the show.
Thank you so much for allowing me this opportunity. This is great.
I think this is something, it's kind of a year-round topic, although we always think about it probably more in the summertime. But we'll probably be able to talk about winter, spring, fall, and that so forth. But maybe what we could do for the audience is start off with, when we think about skin cancer, what is kind of a definition for people to kind of understand what it means when someone says they have skin cancer?
It can mean very different things. And sometimes people don't realize how many different types of skin cancer there are. And skin cancer can be something that's very slow growing that you would get easily removed in the office, or it can be a potentially life-threatening, uncontrolled, fast-growing malignancy on your skin. So saying you have skin cancer can mean very, very different things. And so it's important what type of skin cancer you have. And that's a good message to get out there, because a lot of times I'll try and get a history from a patient and they'll say, well, my mother had skin cancer. And then we're trying to figure out, was it a big excision, little? Was it just something done in the office? Did they have to go somewhere else? So it's important to know if you have skin cancer in your family, to know what type, because it means different things in terms of us watching you and recommending various things.
Right. And you kind of led right into my next question was, can we talk about maybe what are the different types? Because I think sometimes what happens is you hear skin cancer, and of course the word cancer is always difficult to hear no matter which part of the body it is. But with skin cancer, there could be some different types. Could you walk us through what those are?
Sure. And these are the main types, and there are others, many, many others. But the most common, people would talk about basal cell skin cancer. So any cancer is uncontrolled growth. So that means that without treating that, removing those abnormal cells, that you're going to have continued abnormal growth, even if it's slow. So a basal cell is very slow growing and may initially appear to be like a pimple or something very, very minimal. And until it is really noted to be much bigger or bleeding, someone may not really even take notice of that. So it's slow growing, but you have to treat that, because again, uncontrolled growth, it will continue to grow. It will replace normal tissue and require a bigger surgery. So even if a lesion doesn't go into the body, like we fear when we hear cancer, it can cause replacement of a lot of normal tissue. And if that's on your nose and you're going to end up needing an extensive surgery on your nose or ear or lip, that's very significant. So that's basal cell skin cancer. Then there's squamous cell skin cancer. And again, usually occurring in sun-damaged areas, but can occur other places. And that can go into the body, go into the nodes, and then go into the body, but not as quickly. The most concerning skin cancer that we hear about more would be malignant melanoma. And again, even within that skin cancer type, there are many different types of melanoma, and can occur different places. But malignant melanoma is one that, left unnoticed, untreated, does go to the lymph nodes, does go to other organs, liver, brain, and is fatal. If there's going to be a positive, we're catching these earlier, and the drugs for treatment of advanced melanoma are better than ever. So compared with when I started practicing, it's very, very different. I think there's more awareness. People are coming in more to have things checked. We're catching things early. We have better skin cancer prevention tips and habits. And we have, if a person were to end up with extensive disease, we have some really remarkable medications. That being said, we are still seeing many deaths from melanoma, and it's just so tragic. And part of the problem is that it can relate to sun damage or sun exposure that you had decades earlier. And again, sometimes they don't look that bad. I think when we think of a skin cancer, we think of this horrible, irregular, black, brown, like, ugh, like we would notice that. That is not the case when we're diagnosing skin cancer. And I've looked back on the many, many melanomas that I have diagnosed, like even in the past year, 2 years, they really don't look that different from other moles. We're catching them early because they have subtle changes, or we do an exam with a handheld instrument called a dermatoscope, which allows us to see a pattern of pigmented cells that are deeper in the tissue and give us a clue as to how this lesion is growing or how organized it is. And it's a bridge really between our eyes and having the lesion removed and having a microscopic evaluation. So it's critical to go to, I mean, you could say I'm biased, but to go to a board certified dermatologist who is trained in using dermoscopy. Again, it's not just a flashlight or, like a magnifying lens. It's actually going to give us a lot of information beyond what our eyes are able to see. So that's really critical in terms of catching these things earlier, because I can say all these positives about early diagnosis and treatment, but we are still seeing many, many deaths from melanoma.
And, that's what hoping with this show and all that you are doing when with your patients and educating them is to try to avoid that if we can. Now, right. You mentioned like basal as kind of the first level of some cancers. Now, you mentioned that if it's left untreated, it could get larger and, of course, make the removal worse. So, and like you mentioned, especially on a nose or a face, you go from maybe a small incision to something larger, which, of course, then, it's harder to heal and could leave a scar. If it's untreated, could basal turn into melanoma as well?
No. Okay. So the type of skin cancer, that's a great point, because a lot of people do worry about that. Mm-hmm. But a malignancy starts with a certain cell type having uncontrolled growth. So if it's the basal cell that has uncontrolled growth and multiplies and gets larger, it's a basal cell cancer and it just gets more extensive. If it's a squamous cell, that's a type of cell. It's a squamous cell cancer. Okay. That cell has been mutated and is growing uncontrolled. And if it's a melanoma, it's a melanocyte or the pigmented cell. So they don't cross. They don't go into others.
They don't cross into one or the other. Okay. No. And it's basal, and I always want to call it squeamish, and I know it's not. That's not. So it's always hard to say it. Uh-huh. Those two, can they spread to lymph nodes? Can they cause death or no?
Squamous cell can. Basal cell, it would be really almost, they can get very large and they can be somewhat life-threatening, but it usually is within a certain area. It would be that it became so big or on the scalp where it could be an issue. But other than that, no, it's squamous cell can. And actually there's a population that is very vulnerable to the advanced and very aggressive squamous cell carcinomas. And those are the patients that have had an organ transplant. And the reason is because our immune system, which we think of, our immune system is for fighting infection. It also is for fighting malignancy. So there's this constant surveillance of our immune system that, it's picking up any slightly atypical cell and taking care of it. And if you are on drugs to prevent the rejection of an organ transplant, your surveillance of malignancy, specifically the squamous cell malignancy, is going to be impaired. And those patients are very, they're much more likely to get a very advanced and aggressive squamous cell carcinoma. So we monitor those patients, and even better, we want to get those patients before they go on those drugs so that we can aggressively treat any pre-malignant lesions.
And that's great information, because like you said, they do unfortunately take drugs to kind of suppress the immune system, so it doesn't do the rejection of the organ in that. when you made a really good point. As we think about it, people think, okay, what am I looking for? Sometimes we look for that ugly, uneven mole. Sometimes you see these pictures and like, okay, I think I can figure that out if I see something like that. But you said it could be like start as a pimple, it could be something else. And we're going to talk in a minute here, I think, about how important a full body scan is. But if someone's watching, what should they look out for? Because that kind of, to me, opens up to say, wow, there could be a lot of different opportunities on your body if you don't see one of those really ugly looking, moles.
Mm-hmm. So exactly. I think anyone would, if something was really rapidly growing and really looked irregular and just so different, we would ultimately notice it, but that isn't when we want to see it. So I will tell you kind of how things have changed over time. We used to say the A, B, C, and D of malignancy. And so it was A for asymmetry, B for irregular border, C for color or color change, and D for diameter, bigger than like a pencil erasers. Now, there are a lot of benign lesions that fit perfectly in that category. They're really irregular, they're thick, they're warty, and it's really common for people to come in to ask me to look at something that's like an age spot. And we'll get referrals from other doctors for these because they can look really odd and large and irregular with weird colors. So, but then usually that person has a lot of that kind of, they have a lot of those lesions. So I'll tell you where we're more leaning towards, and this is what I tell my patients. Look at your skin and kind of take a bird's eye view. Does something stick out? Like if you're looking at a constellation of stars, is there a brighter one that just doesn't seem to be similar to the others? So the one that looks different from the rest, or the one that's changing, or the one your eye is constantly going to, those are things that I think would lead you to find something in its more subtle early stage. So kind of, and it also makes it less kind of overwhelming for a patient to look at their skin, because if they're thinking they have to look at every single lesion, do the A, B, C, and D on it, would they ever find anything? And then they just give up. I guess, I'd never find it. I'm just going to come in once a year, and that's great. But if something starts growing a couple of weeks after your exam and I'm not seeing you for another 50 weeks, that's a long time to wait. So I really like, just make it simple. Look at everything. Take 5-10 minutes. Like really, this is not an hour thing you need to do. Come out of the shower first of the month or on your birth date. I always say get in your birthday suit on your birth date. So once a month, just look at your skin and see if something just draws your attention to it. Like this one just looks different. I don't know. This one, sometimes people notice elevation. Again, that can mislead you too, because a flat mark can be the concerning one and a raised one can be entirely benign, but just something that's different from the rest.
And I'm kind of shaking my head and smiling to myself because I've been to a dermatologist for many years, and I do remember one time going in and saying, I'm kind of worried about this spot. And he said, I'm not worried about that one. I'm worried about this one over here. It didn't, it wasn't matching to what you think in your mind.
That happens all the time.
Yeah.
I think what's interesting is, let's say someone will come in because their spouse wanted them to check a certain lesion on their back. So usually it's the wife sending her husband, but I don't want to be gender biased, and he'll say, my wife noticed something on my back, and I'll see something on the back that I don't like. There's nothing circled there. There's no direction which one she was worried about, but I'm worried about one, and I remove that. And then he goes home and she removed the wrong one. And so now what I say is for the spouse to circle the one that they're worried about. I'll then, with my little surgical marker, make a smiley face if I think that one's okay right there. And then I'm removing what I want removed. It's oftentimes not the one the patient came in for. And most of the melanomas that we're finding, the patient didn't come in for that at all.
Right. And that really comes back to, what I said we would, visit here is going for at least a yearly skin check. If you can do that, to get to the board certified dermatologist, to have them take a look. And I think sometimes what that's key, like I think you had a great tip, like, hey, your birthday or when you're coming out of the shower, look and that. Now I do know if someone doesn't have a spouse or a partner, a boyfriend, girlfriend, whoever, or brother, sister, anybody to help check. Sometimes you're trying to look, in the mirror and, as your eyes get, worse. And so is that I think that's just like a gold standard. If people can do that, right? To get you to be able to look at a full body just in case, to see if there's anything that you can see that maybe we can't spot.
Right. So there are areas that are just not accessible to an individual to see. So I always say you have to find someone that has your back literally, where they can really see your back. And we can do the full body exam. And it's more than just us looking at you. I mean, we're assessing your risk. So we're taking a family history. We're looking at what your skin type and exposure history has been. We're seeing how much incidental sun exposure you've had. So a lot of people say, well, I never go in the sun. Well, we can look at their skin and we can see, no, there is a lot of sun damage. They may not even be thinking that when they were a lifeguard, as a teenager, that anything relates to that. So we're looking at their kind of risk and their history and extent of sun damage and precancerous lesions and mapping out lesions that we may want to put our eyes on again, or removing lesions that are suspicious or where there isn't certainty. Like, we need more certainty. Our eyes and our dermatoscope can only get us so far. So that exam is really important. And there's also a lot of education that occurs at that appointment. Like, people have a lot of misunderstanding about sunblock. Everyone thinks that they have heard it a million times. They know everything there is to know about sunblock. And I'm still seeing people that feel that they're protected and they are not. So, and other tips for avoiding or, exposure or assessing their risk or minimizing their risk of skin cancer.
And I think, being a person, as I mentioned, having gone to the dermatologist, doing my yearly scan, I mean, it's nice to have somebody look into the scalp even, to see my feet, just
your nails, between the toes,
hands. So one thing I wanted to think about is, and maybe this is a myth, or maybe this could be, you mentioned if there's groups of people that might be more apt for this, would it be, can we assume, or is it a myth or truth, if you're lighter skinned, you're more at risk than if you're someone who's, darker skin or olive skin or different color?
I think that you may have different risks, but you're not in the clear no matter what. And in particular, African Americans are more at risk for a type of melanoma that may occur. I always say fingers, toes, ears, and nose, some of these, like on the feet or under the nails. So you're not in the clear no matter how dark your skin is. And I think a lot of people feel that they're okay because they're like, well, I never burn. Well, that can actually get you to like more exposure, because if you don't burn, you're still getting all the ultraviolet A wavelength, which is different than the B burning ray. It's the ultraviolet A wavelength is a very long, penetrating, damaging wavelength. And actually, a lot of the sunscreens are not as good as we would like in terms of blocking or filtering UVA. So you're not in the clear if you aren't sunbathing either. People go, well, I don't go to the beach. I'm not by a pool. And the sun doesn't know whether you're out there trying to get tan or whether you're playing a sport or you're watching a sport or just eating lunch outside. So there's a lot of exposure that people really don't appreciate as increasing their risk.
And that leads into another really great question, because sometimes we think, oh, we've heard it about, sunscreen and what SPF and, and put it on a half an hour, re-put it on after swimming, all those things. But what would you, if you're educating, your clients and people are watching, what would you tell them when they go to the store to purchase sunscreen?
Okay. So the number is like such an obvious place to look first, but it's not the whole story. So SPF is not like a grade that we're giving a sunscreen. It is purely a measure of UVB protection. And 15 and some 30s, I don't even really think are great. You want a higher number, 40s, 50s. And it is significant, the increase in the protection you get with some of these higher numbers, but that's only part of it. So that doesn't tell you what the UVA protection is. So you can look for broad spectrum, but I always say there's broader, and we don't have a measure for that. There's nothing on the label to indicate that. So there's a couple ways to look at this. One, if you get a zinc oxide product, usually that's going to be like clothing. That's like a physical block. So I like zinc oxide, but a lot of the products out there are not pleasant for people to use. They might be chalky, leave a white cast. People aren't going to use them in the amount that you need to use it in order to get the level of protection you think you're getting. So one thing, just an overwhelming recommendation, is find one that you like you put it on and it looks good and makes your skin look good. We have some that I think could function, even if they didn't have sun protection, they could function as a cosmetic because they really make your skin look good. And then that's better because no one's going to need to remind you to put on, your favorite lipstick, or if your sunscreen makes your skin look good, you're just going to do it. You want that on. But if it feels horrible, it smells bad, it runs into your eyes, you're not going to use it. So find one, first of all, that you'll use. And there are some chemical sunscreens, and I'm in favor of those. They are very good ultraviolet A filters, and hopefully the FDA will be approving some even better ones in the near future. And we often go with our patients, go round and round about chemical versus physical, and people tend to have this negative view of chemicals. Everything is a chemical, and if we're really going to talk about what to be afraid of, the abundance of evidence that ultraviolet radiation is cancer causing. That's something that I think is really important. The chemicals that are in sunscreens, we have done tests, and where people have been covered from head to toe, thick application, not in any way you would actually use the product, sauna suit put on so that it forces absorption into the skin, and you could absorb some at that point, and it still isn't found that that's going to be harmful. So again, more studies necessary. We really want to do them. We want to have the safest possible UVA filters, which is the reason to have a chemical sunscreen. They're better UVA filters if you're not using the zinc oxide as a physical barrier.
And I'm sure it's the debate of cream or if you're using, a spray and that aerosol, because then a lot of times people think, well, I'm not going to use it because you lose half of it in the air and you don't get the spot, coverage. Is there one or the other that, is better to use, or is it personal preference?
In general, a cream is going to be better. You're going to see where you're applying it. The spray, there's one zinc oxide spray that I actually do like, and maybe even more for a reapplication, but it's not like that clear spray that goes in the air and it just magnetically goes to your skin. It's kind of a watery, milky, and then you have to smear it a little bit. I think the sprays were tested more that you had to spray, rub, like 3 cycles of spraying and rubbing it on the skin in order for it to get the protection. So in general, it's kind of nice for kids because you're chasing them, but I think there's other better ways. So in general, I don't recommend the sprays, except there's a zinc oxide spray that I think is very good, and I like that for reapplication.
Okay. And it's great when you were saying that too. And if you're trying to get it on our kids, of course, and get them started and educated early on, because some of us didn't have all that knowledge back so many years and decades ago. But how do you feel about when they say products that hey, are water repellent? You can go swimming in that. Is it still something, even if they say that, you should reapply once you do get out of the water, out of the pool, or?
But they are better. I do like the water resistant products, and there's 2 levels of water resistance. There's 40 minutes and 80 minutes. And so if you are going to be swimming, sweating, I do recommend a water resistant product, but you still have to do the same reapplication.
And in your thoughts, if somebody's watching, what do you think some of the myths are? Maybe with sunscreen, or maybe with just the field of dermatology and the sun?
Well, I think the one I alluded to earlier, which is people minimize their risk. They'll be in my office and they'll say, I never leave the house. And I'm like, Well, I'm not in your house, so here we are. They obviously leave. So all that time driving, the left side of their face is exposed to ultraviolet A wavelength, which is penetrating the glass. So again, that long penetrating, damaging wavelength is going through glass, fog, snow, and people aren't protecting their skin. So that's one thing. In terms of another myth about sunscreens, I would say the tinted sunscreens have been the best and in some cases the worst of things. I loved when tinted sunscreens first came out because, you know, someone's wearing makeup and I'll just go swap the tinted sunscreen for your makeup. That's great. And then it's not an extra step. But if you look at the way, I was starting to see a lot of sun damage in my patients that said that they were meticulous about their sun protection and they were using sunscreen. And I would hand them our tinted. I go, show me how you apply it. And I watch, they're applying a little like you would makeup. And that is not how you need to apply sunscreen. So my new thing is I tell them to put the white stuff on, and it doesn't mean that it has to dry white and chalky, but put that all over where you wouldn't put a tint. You're not going to put a tint all here. It's going to get on your clothing. It's going to get in your hair. Do the white stuff. Let it like really a minute. It absorbs. And then take either a brush or a sponge or your fingers and just add some of the tint over it where you feel like you want a little bit more of that color.
And also when you mention in that, or like sunscreen in that, people forget when it's in the winter time, which can be for many, many months, about getting the sun during the winter time because it doesn't feel as hot, or you don't think it reflects off the snow, or, can you comment a little bit about, what to do in the winter months?
So that's where an ultraviolet A block is really, really important because it's the ultraviolet A that is going to be more prevalent in wintertime. So, and it can be snowing and you're still getting that. So, I do recommend a really good sunscreen. Just make it part of your daily routine. So, there's always a chance that you put it on in the morning and you don't end up leaving the house, but the chances are much more likely if you don't have it as part of your routine, you are going to be out and you're not going to have it. And it doesn't take much. It can be just, a long drive or conversation outside, and you'll end up, developing a lot of exposure. So yeah, all year round. And the products are great now. And ask the dermatologist because we're product junkies. We get this stuff sent to us all day, every day, and we're trying everything that's out there, trying to find the best thing for our patients. And so I remember one time every single time I had a patient that had an excuse for not wearing sunscreen, that it ran into their eyes or they didn't like the feel or the color or whatever. I found a product that kind of would meet that person's need and not cause that obstacle to good sun protection. So there are tons of options. There's sticks, there's powders, there's everything.
And exactly what you said. And what about really quick, maybe about the lips? What kind of things do you look for? We should look for. And we're like, chapstick or some, or lip balm of some kind has SPF. Ooh, so, but is there some rules when it comes to what we should put or look for on our lips?
Yeah. Very much so. And we see a lot of lip cancers and they tend to be very aggressive. So I'm always looking at the lips for any precancerous changes. What can appear to a patient as chapped lips can actually be significant precancerous changes on the lips. And when you get a basal cell or a squamous cell on the lips, they tend to be a little faster, a little more aggressive, and the surgeries can be quite disfiguring. So we really want to be aggressive about that. And I always say in the days of our mom's grandma, they wore that thick, opaque, dark red lipstick, and that was probably pretty effective at blocking the sun. But we're not doing that. We're wearing lip gloss, and that draws the sun to us. So you do need a product. There are some zinc lip products, and they do not look white, and you could put something over it. There's also some glosses that are just look like regular lip gloss that we have one that actually is like a lip plumper and lip gloss, and it has an excellent sunscreen in it. So definitely swap what you're doing for something. And again, the number's not the whole thing. You need to know what is in the product. Is it a good filter, UVA filter and UVB, or not? So
Well, Dr. Sadoff, you have given us so much wonderful information, and hopefully, our audience who's watching, has kind of soaked it in, so to speak, safely. And I really appreciate what you're doing, and thank you for all your expertise and for being on our show today.
Thank you. I really appreciate it.
And I'd like to thank our audience for watching. And again, I hope that all these great tips have helped you or will help you protect your skin. And I hope you have a wonderful day. And thank you for watching. I'm Cindy Kainz.